morning, ladies and gentlemen. I'm Ivy Lin, your MC for today. Welcome to the 4th Head and Neck Cancer Awareness Public Webinar. This year, the theme is Head and Neck Cancer, Are You at Risk? And it is held in conjunction with the International World Head and Neck Cancer Day, which falls on the 27th of 2021. Today's webinar will touch on thyroid, nasopharyngeal, and other head and neck cancers. This is the aim to raise public awareness on the possible signs and symptoms, risk factors, diagnosis, and treatment for this cancer. Due to the COVID-19 situation, we are unable to hold any physical roadshows and public forums due to multiple facilities, and safe distancing issues. We are still very glad that this webinar is being welcomed and participated by many publics, and we are hoping this will bring our public education forum to you virtually. Then you will be able to learn more, especially for today, the head and neck cancer. Let me share some things about NCIS, the organizer for today's event. NCIS is National Specialist Center under the National University Health System. In short, you probably always hear it as NUHS. It is the only public cancer center in Singapore that treats both pediatric and adult cancer patients through its facilities located at National University Hospital, NUH. NCIS also provides cancer services to partners like Ng Teng Song General Hospital, Alexandra Hospital, Jurong Medical Center, Tan Tock Seng Hospital, and extends services to patients at home and in the community. Our comprehensive and personalized services include screening, diagnosis, treatment, and supportive care. Before we start, allow me to highlight that your microphone has been muted by default for all the public. You please type the questions into the Q&A box that you will see at the bottom of the screen, and we will answer your questions, and we'll try our best as much as possible to answer the questions and all the questions if possible. At live, we have 369 people participating. So you can just imagine if we have everyone sending in a question. So please do forgive us. We will try our very best. Our specialists will answer your questions during the Q&A live segment. Do note that this webinar will be streamed live onto National University Cancer Institute Singapore and 365 Cancer Prevention Society's Facebook page. You may visit these pages to review the webinar after today's session. In fact, we encourage you to share this with friends so that you can spread the message. At the end of the session, we will also be sharing with you 3 upcoming events. So don't be too quick to press leave. Don't leave us, stay with us, and we have more to share right after the Q&A session. We would also like to take this opportunity to thank our partners. Without these partners, it's hard to spread the message and to ensure that you gain, the information. 365 Cancer Prevention Society and the sponsors we have are Electa and MSD Pharma, who help to make this event possible. And of course, the volunteers and the people, the heroes behind NCIS who put this together. Without further ado, let us welcome Associate Professor Thomas Low to give us a welcome speech. Our Associate Professor Thomas Low is a Senior Consultant in the Division of Surgical Oncology, Head and Neck Surgery from NCIS. Over to you, Prof. Low.
Hello, hi, good morning, everyone. Just give me 1 second and I'll be with you. Okay, good. Can you all hear me and see what's on the screen?
We can. You want to share your slide view?
Okay. Good morning to everyone. My name is...
everyone. Good morning to you, Dr. Prof.
Good. So I'm Thomas Low. I'm a surgeon at the National University Hospital, as well as at NCIS, and I specialize in the treatment of head and neck cancer. And I've been at NUH for about 25 years or more. Welcome to this head and neck program. And I am always very happy to see so many people who spend the Saturday morning with us. This head and neck program is held annually in July because it really coincides with the Worldwide Head and Neck Day. Head and neck cancers account for approximately 10% of all cancers. And in Singapore, it is the same. It does account for about 10% of all cancers. It is a particularly challenging type of cancer because the head and neck sites is a location where any tumor can affect very important functions such as the speech, swallowing, breathing, taste, vision, hearing, and so on. So therefore, not just the tumor itself, but the treatment can affect these important functions for the patients. In Singapore, head and neck cancers account for about 10%, and you can see here that the most common head and neck cancer is NPC, and the second most common head and neck cancer is thyroid cancers, followed by cancers in the oral cavity, such as cancers of the tongue or cancers of the voice box, what we call the larynx. So these are the common types of cancers that as a head and neck tumor group we deal with. So today I am happy to have 4 of my colleagues who are excellent clinicians in NUH and in NCIS who deal with patients with cancers of the head and neck. They are Dr. Larry Lim, Dr. Donovan Yu, Dr. Chong Wan Ching, and Dr. Francis Ho. Together, you'll notice that there are 2 surgeons there, and there's a medical oncologist who specializes, Dr. Chong, who specializes in chemotherapy treatment, and Dr. Francis Ho, who is the head of radiation oncology, who specializes in treatment using radiation. So together, you notice that as a group, we function together. And as well, we have other colleagues too in our head and neck tumor group that look after, for example, the imaging and also the pathology, right? Looking at what type of cancers, the type of cells, and so on. So there are many people who are involved in this specialty of head and neck cancers, and it really does take, in some ways, a village to treat a patient. And at the end of the day, this is really what we want. We want the patients to get well. We want the patients to carry on with life in as full a manner as they were doing before they were diagnosed with cancers. And so with that, I'm just going to pass back to Ivy, and we can begin the program. And once again, I thank you to every one of you who are tuned in this unprecedented times where we have to conduct a webinar like that. Obviously, I would certainly like to meet all of you in person. But whatever it is, I'm sure we will get out of this. And sooner or later, we'll be able to meet. Thank you very much.
Thank you, Professor Loh. Thank you very much. I have the good luck of meeting Professor Loh twice in person, and both times he was actually in his surgical scrubs. So I think he does live, at the OR. And thank you very much, Professor Loh. Next up, we have our first speaker, Dr. Lim Swee Hien, and he is the Associate Consultant of the Department of Otolaryngology head and neck surgery of the National University Hospital. And Dr. Lim will be sharing with us head and neck cancer. Should I be worried? Over to you, Dr. Lim.
Good morning, everybody. Thank you once again for joining us today at this forum on head and neck cancers. I will start off the talks today by giving a broad overview of head and neck cancers in general. Following this, my fellow speakers will then speak in more detail about the two most common head and neck cancers in Singapore. So during this part of my talk, I would like to address these frequently asked questions about head and neck cancers. Firstly, what are the common head and neck cancers? Second, who is at risk of developing these cancers? Are there any symptoms that are suspicious? And when should you seek medical attention? Finally, I will talk a bit about how head and neck cancers are diagnosed and treated. So when we talk about the head and neck, we divide them into various subsites by their location. This would include the nasal cavity, which is in the nose, the nasopharynx, which is at the back of the nose, the oral cavity, which is the mouth, oropharynx behind that, larynx, which is the voice box, the hypopharynx, which is behind the voice box, and finally in the neck, we have the thyroid, as well as salivary glands. Looking at the numbers, the most common head and neck cancer in Singapore is actually nasopharyngeal cancer, which is cancer of the back of the nose, closely followed by thyroid cancer. And collectively, these two form about 5% of all cancers in Singapore every year. Less common, but no less significant, include cancers of the mouth, voice box, throat, salivary glands, as well as the nasal cavity. So head and neck cancers are fairly significant in Singapore. And according to the Singapore Cancer Registry Annual Report in 2018, nasopharyngeal cancer is the 8th most common cause of cancer-related death in males in Singapore. And thyroid cancer is actually the 8th most common cancer that arises among the females in Singapore every year. Common risk factors for head and neck cancers include that of smoking, alcohol abuse, and family history. Family history is significant in certain cancers, especially that of nasopharyngeal cancer, as well as thyroid cancer. A history of radiation exposure, whether occupational, accidental, or even medical, can increase one's risk of developing a head and neck cancer. Last but not least, certain viruses are associated. This would include the Epstein-Barr virus, which is associated with nasopharyngeal cancer, and the human papillomavirus, which is associated with oropharyngeal cancer. Many head and neck cancers present with symptoms that are not very obvious at the start. And this is because these cancers are located in an area where it may be very deep in the head and neck, and symptoms may not appear until the tumors are very large, have invaded into surrounding structures, or they have spread into other areas, for example, the lymph nodes in the neck. So one of the common symptoms is that of lump in the neck, and this could be at the front or the side of the neck, or even near the angle of the jaw. Often this is because cancers have spread to the lymph nodes in the neck, and thyroid as well as salivary gland cancers do present with a lump as their first symptom most of the time. Other suspicious symptoms would include a non-healing ulcer in the mouth, or one that is persistent or growing over time. Persistent blocked ear, which is one of the most common symptoms of nasopharyngeal cancer. Persistent and unexplained ear pain may also be a symptom, and this is because the nerve that supplies the ear has many branches that also supply the voice box, the mouth, and the back of the throat. And sometimes patients with cancers of these areas experience what we call referred pain, where the pain is experienced in the ear, but the true problem may lie elsewhere. Of course, patients may also experience difficulty or pain on swallowing, change in the voice, or persistent blood in the saliva. In general, you should see an ENT doctor if you have any symptom in the ear, nose, or throat, or any part of the head and neck that you find is very unusual, you're unable to explain it, and the symptom does not go away. So my fellow speakers are going to talk more in detail about nasopharyngeal cancer as well as thyroid cancer, because these two are the most common head and neck cancers in Singapore. So for the next part, I will briefly touch on the rest of the head and neck cancers, which are less common, but also very important. So first, we have the oral cavity. The oral cavity essentially refers to the mouth, and there are actually many areas in the mouth that can develop cancer, including the tongue, the bottom of the mouth, the inside of the cheek, the gums, the lips, as well as the roof of the mouth, which is the palate. The most common area where cancer of the mouth can develop is on the tongue, and it is usually at the side of the tongue. So cancer of the mouth is commonly caused by smoking, alcohol abuse, but it can also be related to betel nut chewing, as well as dentures that are not fitting well. Some symptoms that patients may experience include an ulcer that does not heal over time, or it may continue to enlarge despite the treatment with topical medications. Sometimes patients may experience a lump in the mouth that could be painful, could cause bleeding. And in patients who wear dentures, sometimes they may find that the dentures don't fit so well or become unable to put on because of a tumor that is growing underneath. Other symptoms would include that of ear pain, bleeding, and a neck lump if the tumor has spread into the lymph nodes of the neck. So in these pictures, these are examples of tumors that can occur in the oral cavity. And in the top two pictures, we can see that these are two tongue tumors that have arisen from the lateral border or the side of the tongue, which is the most common area where tongue cancers can develop. Of course, cancers can also arise from the top of the mouth or the palate, for example, in the bottom left picture, and they can also arise from the inside of the cheek, which is what you can see in the picture on the bottom right. Behind the oral cavity is what we call the oropharynx. And the oropharynx consists of the tonsils at the two sides of the back of the throat, the soft palate, which connects to the uvula. The uvula is the little structure that hangs down in the midline and the back of the throat. And it also includes the back of the tongue. And the most common sites for oropharyngeal cancer to develop are the tonsils, followed by the base of tongue, which is the back of the tongue. Now, oropharyngeal cancer is also caused commonly by smoking and alcohol. But increasingly, we are seeing patients who have oropharyngeal cancers associated with HPV infection, which is a viral infection. Symptoms of oropharyngeal cancer may include a persistent sore throat, especially if it's one-sided. They may have difficulty in swallowing because the tumor is at the back of the throat or back of the tongue. They may have blood stains in the saliva, ear pain, which is a referred pain, or a neck lump. So we mentioned HPV earlier, and HPV stands for human papillomavirus. And this is a well-known virus that is transmitted mainly via sexual contact. It has increasingly been found to be associated with oropharyngeal cancers, especially in developed countries. Currently, it accounts for about 20% of newly diagnosed cases of oropharyngeal cancer in Singapore every year. And it is even more common in the West. For example, in the US and certain parts of Europe, it accounts for 60 to 70%. Fortunately, HPV positive tumors, they do have a better prognosis as compared to HPV negative tumors. They respond much better to treatment. They are less likely to recur locally, and they are also less likely to spread to the rest of the body. These pictures show examples of cancers that have developed in the oropharynx. So in the picture on the left, we can see that the patient's right tonsil, there is a mass, there is a lump there, and this is a cancerous lump. And in the picture on the right, we can see that this patient has developed a cancer of the soft palate. Moving on, the next area that I'm going to talk about is the larynx. So the larynx essentially is the voice box, and it is located in the front of our neck. And the larynx is important for us to, number one, breathe, number two, produce a voice, and it also helps us when we swallow. And in the picture all the way on the right, we can see that it's a normal looking larynx or voice box. And this is not something that we can see ourselves, of course. We need to use special instruments to have a look in that area. And you can see that there are two white lines that are V-shaped, and these are the vocal cords. So laryngeal cancer is caused usually by smoking as well as alcohol abuse. And because the larynx is involved in voice production, one of the common symptoms of laryngeal cancer is that of a change in the voice. Patients may also develop pain in the throat or difficulty swallowing. They may cough up blood if there's bleeding from the tumor. Sometimes if the tumor becomes very large, it may obstruct the windpipe, then therefore leading to patients feeling breathless or experiencing noisy breathing. And as usual, they may also get ear pain or a neck lump. So these are examples of patients who have developed cancers of the larynx. And we can see in both of these pictures that on the vocal cords, there are lumps that look irregular. Both of these patients came to see us because of change in the voice and were both found to have laryngeal cancer, which were eventually treated. Last but not least, the salivary glands can also develop cancers. And salivary glands can be divided actually into the major and minor salivary glands. The major glands include the parotid gland, which is just below the earlobe, the submandibular gland, which is near the angle of the jaw, and the sublingual gland, which is in the mouth. We also have many minor salivary glands that are located all over the nose, mouth, as well as the throat. The majority of salivary gland tumors arise from the parotid gland, which is near the earlobe. Fortunately, most of these tumors are benign. However, if you notice that there is a salivary gland lump that is rapidly increasing in size, if it is painful, if it is associated with skin redness or ulceration of the skin over it, or if there's facial weakness, or tongue numbness, these are symptoms that are suspicious for a cancerous lump. So these two are examples of patients who have developed cancers of the parotid gland. And we can see in the picture on the left that this is a small lump in the parotid gland that is just under the earlobe. Whereas in the picture on the right, you can see that some parotid tumors may be much larger, extending all the way from the earlobe all the way down into the bottom of the neck. So the next thing that you may ask is, how are patients then evaluated, or what will you do to me if I come to see you in the clinic? So the first thing that we will do is ask many questions to find out more about your symptoms, your risk factors, and your medical problems. And next, we perform a physical examination, and this will almost always include something called a nasal endoscopy. And this is a procedure where a very fine endoscope is placed through the nose to visualize the nose, back of the nose, as well as the back of the throat and voice box. It is a relatively painless procedure, and we often do spray some local anesthetic to make it more comfortable for the patient. If we do identify something that looks suspicious, then the next step is that we need to do a biopsy. This biopsy may be done in the clinic. For example, if you have a thyroid lump or salivary gland lump, we may use a small blood-taking needle to draw out some of the cells for testing. If we see something abnormal in the mouth or the back of the nose, we can also take some of the tissue for testing in our clinic. However, there are some areas, for example, the voice box, where it's not so accessible for biopsy, and we may then have to put the patient under anesthesia in order to access that area, to evaluate it, and to take some tissue for examination. Once cancers are confirmed, they often need some form of imaging. This imaging will tell us the stage of the tumor, as well as whether it has spread to the rest of the body. Sometimes we may do an ultrasound, and this is usually for thyroid cancers. But for most other cancers, usually a CT scan or an MRI scan, or even both, may be performed. In terms of treatment, head and neck cancers can be treated in several ways. Some cancers are often treated with surgery. This includes cancers of the mouth, the thyroid gland, as well as the salivary gland. Some cancers are treated with radiotherapy, for example, cancers of the nasopharynx. There are other cancers which can be treated by both equally well, and these include cancers of the voice box as well as the throat. When cancers are at a more advanced stage, then they may require more than one modality of treatment, meaning that they may need surgery followed by radiation or even chemotherapy post-op. Or sometimes they may be treated with both chemotherapy and radiotherapy at the same time. In summary, the most common head and neck cancers in Singapore are nasopharyngeal and thyroid cancer, which we are going to talk about in a lot more detail later on. Head and neck cancers can present with symptoms that are not obvious, so do consult a specialist if you do experience any persistent or unexplained symptom anywhere in the ear, nose, throat, or the head and neck. Finally, do contact us if you have any issues. This is the email of the ENT clinic at NUH, and that is our website. If you would like to fix an appointment with us, you can also call the NUH appointment line at this number. Thank you very much.
And next up, we're going to have Dr. Donovan Yu, our consultant from the Division of Surgical Oncology of Head and Neck Surgery from NCIS Singapore. And Dr. Yu here will be sharing with us thyroid cancer, who gets it and what can be done. Over to you, Dr. Yu.
Morning, everybody. Thank you for joining us today. I'm Dr. Donovan Yu. I'm one of the head and neck surgeons at the ENT department in NUH. I'm also part of the surgical oncology unit in the head and neck group at the National Cancer Institute. Today, I'm going to be touching a little bit about thyroid cancers and trying to give somewhat of a flavor as to what we do in terms of management of thyroid cancers. So I thought we'd start off with something simple, really finding out what exactly is the thyroid gland. So the thyroid gland is a butterfly-shaped gland at the center of the neck. It's really right at where the windpipe is. And beside the gland, there are several important structures that are important in terms of surgery. So one of them is the nerve to the voice box. This runs behind the gland and goes up and basically supplies the nerve to movement of the vocal cords. And that's important for us when we talk and even when we breathe. On top of the gland, there are small little tiny subglands called parathyroid glands. And these are important for control of calcium in the body. So these are all the closely related structures to the thyroid gland. So what does the thyroid actually do? The thyroid is actually a vital organ in terms of our daily living. The thyroid produces a hormone called thyroxine, and thyroxine is very important in terms of how it controls a lot of the metabolism. So one of the things that is very important, the thyroxine helps to control things like the heart rate, temperature. It's involved in development of the brain, nerves as well, and also it involves with the digestion. Essentially, the thyroid hormone is essential and critical for daily living. So in all our patients who have undergone surgery for a total removal of the thyroid gland, they need to be put on a kind of supplement, a thyroxine supplement that replaces the function of this gland. So let's talk about thyroid cancers next. So when we talk about thyroid cancers, there's actually a lot of different types of thyroid cancers. But I think just to make it very easy, very simple, the vast majority, and we're talking about 85 to 95% of patients that we see actually have papillary thyroid cancers. And that's by far the most common subtype of thyroid cancers there are. So for the ease of discussion, we'll just talk about the majority, about the papillary thyroid cancers for the rest of this talk. So how common are thyroid cancers? So this is a graph that we have from CDC in the United States, and it shows a almost 20-year trend in terms of the thyroid cancer cases. So as you can see, from 1999 to about 2015, there's been really a high increase in terms of newly diagnosed thyroid cancers. Based on the estimate, it's assumed that about 15.5 per 100,000 new cases of thyroid cancer are diagnosed every year. In terms of absolute risk, approximately 1% of all adults will be diagnosed with thyroid cancers in their lifetime. So what this kind of shows is that this is actually a very common type of head and neck cancer. In fact, it's one of the most common types of head and neck cancers that we see at NCIS as well. And why is that so? I think a lot of data seems to indicate that this is really due to improvements in terms of our imaging and our availability of using imaging to identify and diagnose these patients at early onset. So what are the risk factors involved in terms of thyroid? So thyroid cancers are more common in women. We know this, and there are multiple studies, and even our numbers would show that there's almost a 3:1 predilection in women compared to men. There's also a little bit of a difference in terms of the age group. Women tend to present earlier, about 40, 50 years of age, while men tend to present themselves at about 60 to 70 years of age. That being said, thyroid cancer can occur at any age. So it is also sometimes seen in children where thyroid cancers may be diagnosed. In terms of family history, so patients with a first-degree relative that has thyroid cancers have a higher risk of developing thyroid cancers themselves. In terms of environmental or things that you can change, a lot of patients have always asked us whether smoking, alcohol, or certain types of food are more at risk of developing thyroid cancers. The good news is that there's so far no evidence that would suggest that what you eat or your habits may actually change in terms of your risk profile. But what has been shown to have a higher risk of developing thyroid cancers is patients who have had previous radiation. And this is more so for some patients who have had a radiation to the head and neck when they were kids. So moving on, what is the most common symptom? So by far, the most common symptoms are a neck lump. This lump is usually in the center of the neck. Occasionally, you may have neck lumps on the side of the neck. In general, a lot of patients are always under the misconception that there's always pain. That's not usually the case. We usually see patients who present with painless neck lumps, and only a small percentage of the patients actually have pain when it comes to thyroid cancers. Talking about other kinds of symptoms, when the lump starts to put an effect on the surrounding structures that we talked about in the first slide, it can cause changes to the voice. It can also cause airway symptoms such as difficulty breathing, sometimes even coughing out of blood. And sometimes if it is large enough and causes compression on the swallowing function, then there can be disruption of swallowing. This is usually not very common though. So how do we work up and how do we treat thyroid cancers? So I think the most important thing that that your doctor would do for you is to get a good history, find out your risk, find out your symptoms that you're having, and have a good physical examination, really feel where the lump is, whether or not there's any other lumps in the rest of the neck. And one of the things that we would do is to put in a little camera into your nose to take a look at the voice box to see that it's moving well and to see if there's anything in the windpipe that may be suspicious. In terms of further workup, we usually use ultrasound to look at the thyroid gland as well as the lump in question to see the different types of characteristics that may be suggestive or more suggestive for a cancer. Some patients who have suspicions of lymph node or more advanced disease may consider CT as well to further look at the thyroid nodule and the involved structures. One of the most important tests that we do is a fine needle aspiration cytology. And what this is actually a small needle that's inserted into the lump. And from there, cells are taken out, and these cells are looked under the microscope to see if there's any signs of cancers within the cells. In general, this is actually very well tolerated, and a lot of times we do this in the clinic, and patients actually there's a slight discomfort, but generally quite acceptable. So let's talk about treatment. What is the treatment? So by far, I think the best treatment for thyroid cancers is surgery. surgery involves removing the thyroid gland, either one lobe or the entire gland itself. This is obviously depending on the extent of disease. In some cases, we also do a lymph node dissection, and this is a procedure where we remove the surrounding lymph nodes that are suspected to have involvement of thyroid cancers, and basically try to clear out all the thyroid cancer elements that are in the neck. Some patients, after undergoing surgery, may require a secondary treatment, and that's that's using radiation treatment. And by far, I think most patients are treated with radioactive iodine, and this is done with the nuclear medicine doctors. A very, very small subset of patients may require traditional X-ray radiations. However, that's not common at all. So, like I mentioned, these treatment is actually, they are very, very effective. And I would say that approximately about 90% or even up to 95% of all patients, especially with papillary cancers, would be able to achieve a complete cure. And that's usually been our results and is consistent with the rest of the world as well. So moving on, I'm just going to share a little bit about what we're seeing being developed in terms of treatment strategies for thyroid cancers. One of the things, as I mentioned, we're able now to identify cancers that are very, very small. And there's a kind of trend now to actually see if we can actually not even treat these cancers. And so far, it would seem that for some patients, observing the cancers and not doing surgery for them may be a viable option. And in fact, there are studies that have shown about 5-year, 10-year results where the cancer doesn't grow, stays at that same position and doesn't cause any symptoms whatsoever to the patients. Moving on in terms of treatment advances, we are actually seeing newer treatment options such as minimally invasive type surgeries. And the other thing that's been coming up is targeted therapies, where the treatment of thyroid cancers are treated by medications and certain special types of medications that can target the thyroid cancer itself. And these are so far has shown promise in advanced cases. So these are what we see in terms of the development of new management approaches in terms of thyroid cancers. And with that, I think I'll end my talk here, and we'll leave some time for questions. If there's anything that you may want to clarify, please just ask subsequently. Thank you.
Next, we are inviting our third speaker for today, Dr. Chong Wan Chin. She's a consultant of the Department of Hematology Oncology of the NCIS. And Dr. Chong will be sharing with you on the topic of chemotherapy for nasopharyngeal cancer. Who needs it? Over to you, Dr. Chong.
Good morning, everyone. My name is Wan Qing, and I'm a medical oncologist at National University Hospital. Thank you for joining this webinar on a Saturday. It's my pleasure to be here to share with all of you more about nasopharyngeal cancer, or NPC for short, and role of chemotherapy in the treatment of NPC. This is the outline of my talk. I'll be sharing the epidemiology, risk factors, and symptoms of NPC. I'll explain what chemotherapy is, who needs it, how is it given, and what are its side effects. Lastly, I'll briefly discuss the promising therapies in the treatment of NPC. Nasopharynx refers to the narrow tubular passage behind the nasal cavity, and NPC refers to cancer involving this area. Some people call it nose cancer, but it's certainly different from nose cancer, which is cancer of the nasal cavity. NPC used to be among the top 10 cancers among males in Singapore. Thankfully, the outdated data from Singapore Cancer Registry for 2014 to 2018 show that NPC has fallen off the top 10, although it is still ranked 8th among cancers causing death in Singaporean men. The reasons for this decline are unclear, although we could possibly attribute it to lifestyle changes associated with rapid economic development over the past years. As an example, there has been a decrease in the use of salted fish to feed infants, and reduced exposure to traditional preserved food. The declining incidence may also be due to population shifts as a result of change in immigration patterns. NPC is more common in males than in females, and in Chinese, followed by Malays. I hardly see it in Indians, and this may be due to differences in genetic predisposition and lifestyles. And of note, unlike other cancers, NPC tends to affect younger people who are economically active and supposedly at the prime of their lives. Hence, there is still significant socio-economic impact for NPC, even though overall it's no longer a very common cancer. So what are the risk factors for NPC? NPC is not simply due to a single cause. Its cause is multifactorial with interplay of factors such as, firstly, Epstein-Barr virus infection, which is common in this part of the world. Secondly, genetic predisposition, where having a first-degree relative with NPC increases the risk of developing one by 7-fold. And that's the ethnicity predisposition, mainly in the Chinese that we mentioned earlier. And lastly, environmental factors such as intake of preserved foods and smoking. Because NPC originates from deep behind the nose, patients often go on for a prolonged period without any symptoms. And unfortunately, when diagnosed with NPC, the cancer is in advanced stage already. Some of the earlier symptoms include blocked nose or nosebleed, blocked ear or reduced hearing. At later stages, patients develop neck lumps and even double vision or numbness over the face. What is chemotherapy? Most of our normal body cells, once fully grown, don't divide and multiply much. On the other hand, cancer cells are cells that grow uncontrollably and they divide more quickly than healthy cells. Chemotherapy are drugs that target cells that multiply quickly, and hence it is more likely to kill cancer cells. But it can also affect the fast-growing healthy cells in our body, leading to side effects. It is a common misconception that chemotherapy is just one particular type of drug. This busy slide is to illustrate the various types of chemotherapy drugs that we have, and they work by affecting different pathways of cell growth. The chemotherapy that we use most common in NPC is cisplatin, which works by affecting the cell's DNA. Who needs chemotherapy? Chemotherapy may be given for various reasons. In patients with advanced NPC, but still confined to the head and neck region, we give chemotherapy concurrently with radiotherapy. In this setting, the chemotherapy strengthens the radiotherapy effect and helps to kill the microscopic cancer cells that may have gone into the bloodstream, hiding the rest of the body. This in turn improves the cure rate. Some patients may also need additional chemotherapy to shrink the cancer first, to facilitate the delivery of subsequent concurrent chemoradiotherapy. In patients with NPC that has spread to other parts of the body, chemotherapy is given to control the disease with the aim to keep the patient stable for a longer period of time. As a summary, with the exception of early stage NPC that's confined to within the nasopharynx, there's role in giving chemotherapy to improve cure rate or increase survival. So how is chemotherapy given? Well, we do have few chemotherapy drugs that can be taken in the form of tablets. However, most chemotherapy has to be given intravenously, which meant given directly into the bloodstream. NUH Cancer Center is situated at level 8 to 10 of NUH Medical Center. Patients who need intravenous chemotherapy will go to level 9, which is our chemotherapy center. After registration, the nurses will call the patients in to sit inside the treatment area. At the treatment area, the nurse will first place a plastic cannula directly into the vein, then connect a bag of chemotherapy to this cannula via a pump. The pump helps to control the rate at which the chemotherapy is given into the bloodstream. When the bag of chemotherapy is given completely into the vein, the nurse will remove the plastic cannula and the patient can then go home. Chemotherapy is given in cycles, and the duration of the cycle varies depending on the setting and the type of chemotherapy used. When we give chemotherapy concurrently with radiotherapy in the treatment of NPC, we tend to give it as a small dose once a week, while radiotherapy is given daily for 33 fractions. So I've tried to illustrate this using these calendars. The triangles represent the daily radiotherapy, while the stars represent the weekly chemotherapy. Generally, we start the chemotherapy the same day or the next day when radiotherapy commences. Chemotherapy also ends when radiotherapy completes. During the entire radiotherapy, we can give up to 7 cycles of weekly chemotherapy. As mentioned, chemotherapy targets cells that multiply quickly. Fast-growing healthy cells are hence more likely to be affected by chemotherapy, causing what we call side effects. Fast-growing healthy cells include the hair follicles, cells lining the surface of mucous membrane and skin, and blood cells. Hence, one common side effect of chemotherapy is hair loss, with varying degree depending on the type of chemotherapy used. Thankfully, the chemotherapy we use in NPC usually causes only mild hair loss, and when chemotherapy is stopped, the hair will grow back. Another common side effect is ulcers or inflammation of the lining of our mouth and gut. This can be managed with the use of topical creams and mouthwash, and sometimes requiring the use of painkillers. Nausea and vomiting is one of the most feared side effects of chemotherapy. But in this day and age, we do have very good anti-vomiting medications that doctors will prescribe in advance to try to prevent nausea and vomiting altogether. And if some patients do develop nausea and vomiting, they can take the additional standby anti-vomiting medications prescribed. Lastly, chemotherapy can affect the blood cells, and one particular blood cell of concern is the white blood cells, which are our immune cells. When our immune system is low, we are likely to catch an infection. Hence, patients on chemotherapy do need to watch out for fever, which is often the first sign of infection. And when they do develop fever, they need to seek immediate medical attention. Avoiding sick people in crowded areas will help to reduce the risk of catching an infection. A promising new treatment for NPC is immunotherapy, which refers broadly to therapy that uses the immune system to fight against cancer. There are different ways to do so. One way is through administering immunotherapy drugs called checkpoint inhibitors. To explain simply how it works, most times our immune cells, like the T cells, can recognize and target cancer cells. But the cancer cells escapes detection by the immune system through a pathway using PD-L1, which kind of knocks out the immune cells and makes them dysfunction. When we administer checkpoint inhibitors that target the PD-1 or PD-L1 pathway, the drugs acts like a helmet for the immune cells, so that now they can't be knocked out by the cancer cells and they can perform their job in killing the cancer cells. In an international clinical oncology meeting held last month, the Chinese oncologists shared promising results of their studies using immunotherapy together with chemotherapy as upfront treatment in patients with advanced NPC. With the addition of PD-1 inhibitors, there were improvements in terms of shrinkage of NPC and the duration for which NPC was controlled. Other methods include removing the immune cells from our body, teaching them how to recognize NPC, and putting them back into the body. In NUH, we had run clinical studies with this method of immunotherapy, and I do have a patient with advanced NPC whom, after going through immunotherapy on this study, has his cancer remains controlled for the last 3 years without needing any additional treatment. In summary, chemotherapy improves cure rates and prolongs survival in patients with NPC. Chemotherapy side effects are generally manageable. While we can't control genetic predisposition or EBV infection, we can try to eat less preserved food, stop smoking, and increase our fruit and vegetable intake. This will help to reduce our risk of developing NPC. With that, I thank you for your attention.
Thank you, Dr. Chong. Thank you so much for your presentation. Thank you. And we'll come to our last speaker for today, and please do stay on. We will have our Q&A session. Right now, we have more than actually 23 questions that is has been pulled in. So if you have any questions, please do put them in the Q&A. We are inviting our fourth speaker for today, Dr. Francis Ho, our head and senior consultant from the Department of Radiation Oncology from NCIS. And from Dr. Ho, we will hear about radiotherapy for nasopharyngeal cancer, what to expect as a patient. Over to you, Dr. Ho.
Hi, everybody. I hope you've enjoyed the talk so far. Today, in the next 15 minutes, I'm going to just bring you through what to expect as a patient when undergoing radiotherapy. Or perhaps you just really want to know a little bit more about what are the treatment options for cancer, and radiotherapy would be one of them. My name is Francis, and I'm a radiation oncologist, which simply means that I'm a doctor that specializes in using radiation to treat cancer. Now, today we're going to talk specifically about using radiotherapy to treat nasopharyngeal cancer. Now, you have heard about the various ways in which we treat nasopharyngeal cancer. And now this is kind of the last part of the talk, and I'm just going to start without further ado. Now, as an overview, we'll just kind of go through what exactly is radiotherapy. We will talk about why is radiotherapy given. We'll talk about when is radiotherapy given, how it is given, and of course, many people will want to know what are the side effects. But more important than that is what are the benefits of radiotherapy and what do I expect before and during, after radiotherapy. So what exactly is radiotherapy? The photo that you see is actually a picture of my colleagues delivering radiotherapy to a patient. And, you know, a lot of people have this idea that, you know, radiotherapy is almost like a bomb that is going off in your face. Perhaps, you know, that was the kind of bad reputation that we had many, many years ago. The truth is, radiotherapy has come a long way, and I think that's definitely not what it is. The animation video that I'm about to play would give you a good idea of what radiotherapy would look like. And you can actually see that as radiotherapy actually passes through the patient's body. In this case, what we're treating is actually the nose cancer, the nasopharynx area. The actual treatment would actually be invisible. But in this particular case, we have kind of used colors to kind of show you how the radiation might look like if it was actually visible. So radiotherapy essentially is just, you know, the use of X-rays to treat cancer. And many of you might have taken a chest X-ray before, and you would realize that you can't feel the radiation, and that's how it is during radiotherapy as well. You can't actually feel it. So why is this radiotherapy given? And obviously, I think the aim is actually to eradicate the tumor. But in some other circumstances in nasopharyngeal cancer, we can also give it to improve symptoms. And some patients in advanced stages of this cancer may experience pain, bleeding, obstruction. So this is actually quite useful to improve these symptoms as well. Now, when is this given? Again, the treatment of nasopharyngeal cancer has actually changed over the years. And it used to be quite straightforward, and it actually isn't very straightforward now. But to kind of make it simple for everybody, radiotherapy can actually be given as a standalone treatment. It can also be given together with chemotherapy. So radiotherapy is typically given on a daily basis, where the chemotherapy often is not, as Dr. Chong would have talked about earlier. And radiotherapy can also be given after a course of chemotherapy a few courses, in fact, of chemotherapy has been given, or in which case radiotherapy can be first given, subsequently follow up by chemotherapy. And like I said earlier, it can actually be used for controlling of symptoms. So how is this given? The step One would be whereby most people would be familiar with. You would see consult a specialist like myself. And thereafter, we would explain to you what I'm going to explain to you today. And we would obtain your consent for treatment. And at the same time, to prepare for the radiotherapy, we would actually get you to see a few other of our colleagues, and this would include the dietitian. Maintaining a good diet and maintaining your weight is extremely important and has been shown multiple times to actually correlate with a better outcome for cancer. So that is something our dietitian helps us with. The speech therapist would teach, usually before radiation, some exercises to actually help improve the outcome of swallowing after the treatment as well. The dentist plays an essential role, and they have to give the go-ahead before we actually allow patients to start radiation. And after that, we go on to what we call a rehearsal stage. In medical terms, we call it a CT simulation. So CT means that we actually acquire a CT scan of the patient who's going to undergo the treatment, and that is done in conjunction with fitting of a mask. And this mask would help to keep the patient still. We'll show you a video in a short while what it might look like. And this is a picture of the mask, and it basically is a sheet of plastic with holes that allows you to continue breathing, obviously, but it helps to keep you still. The next step is actually radiotherapy planning. This can take anywhere from a few days to a couple of weeks. And the whole idea when doing this is really to make sure that we target the tumor and we make sure that we don't miss it. At the same time, we try to reduce the radiation dose to all the other important organs that the patient has. And the next step is actually treatment and review. And this is where we deliver the radiation. And this picture actually shows a block of what we call collimators. And this basically help to shape the radiation beam. And you can see that these blocks basically change the shape in accordance to the radiation beam. Now, the last one is something that most patients would look forward to, because at the end of treatment, they will come back for their follow-up. And typically, after the follow-up, we would be going through the response of the treatment, and also to after the patient has had a good response to treatment, we will continue to follow up to make sure that the tumor doesn't come back. Now, I promise you a video of the mask. This is exactly how the mask looks like in close up, and you can actually see this video. So you can see that the therapist is actually taking the mask out of a warm water bath. And as the temperature of the mask drops, the mask would actually fix the shape, and you would have final product that basically fits the shape of the patient. Now, after that, what we actually do is we move on to this stage of radiotherapy planning called contouring. And what we actually do as specialists is to basically mark out where the tumor is. And you can see that in this particular area, we have actually marked the red area as tumor. But we actually treat most of the nasopharynx, and we actually mark that out as well. And then we know that because the nasopharynx tumor can actually spread to the surrounding area, we actually enlarge the area that is being treated. At the same time, most patients would have had an MRI done. We would actually do overlap of that with the other image in order to actually help us identify the tumor better. And once that is done, we kind of know the area that we're going to target. And we do this thing called a radiotherapy planning. And when we do radiotherapy planning, it's actually quite simple. What we want to do is to maximize the kill of tumor and to reduce the damage to the normal organs. Now, what then happens is that the computer then basically puts on a radiation dose, and you can see that the orange color actually correlates to where the area of tumor that we want to be treating, and that gets a very high dose, whereas the green color color wash basically overlaps with the larger area that we have demarcated that is considered at high risk of being involved by the tumor, that gets a slightly lower dose. And you can see that the brain at the back of this patient behind the tumor actually gets very little dose. So this is what a final radiation plan will look like. It looks fairly complicated. And what you have here is radiation beams coming from 7 different angles. And as a result of that, we are able to basically customize the dose to the patient. So many of you would ask, what are the side effects that we can actually expect when going through this treatment? Like I said earlier, while you may actually not feel anything as the X-rays or the radiation passes through you, there are some side effects that we would expect. And many of this happen during the radiation. And I would say 80% of patients would expect side effects during the treatment. And late effects happen often only 6 months later, while minority of patients would actually have these side effects. Now, most of the side effects that happen during the treatment is a result of inflammation, and you would have a dry mouth. You would imagine that with inflammation of the nasopharynx area, the throat area, you might get ulcers, and it will make swallowing painful. And it can also cause the skin to become inflamed as well, and therefore the skin can become red and it can peel. And at the end of the day, radiation requires daily traveling, and the radiation itself also causes tiredness. And all of that adds up, and it causes significant weight loss. You know, I always joke with my patients that this is unfortunately the world's most successful weight loss program. And often patients would lose a few percentage points of their overall weight during the treatment, and that's actually fairly common. It can be up to 10%. So the late side effects is that some of these side effects that happen during the treatment, like the dry mouth, can actually persist and be late side effects. You would also expect some scarring of the muscles in the neck and the skin. You would expect some hair loss at the back of the head. There might be some swallowing difficulties, hormonal changes, impairment to the hearing, and tooth decay. And while this seems like a very, very long list, the number of patients that actually get affected is less than 5%. And there's also this very common question that people ask, can radiation cause cancer? Second cancer that happens, say, 10 years later. And of course, you know, that is something that is real, and there is a risk, although the risk is low. It's roughly about 5 to 6 in 1,000. So what are the benefits now that we've gone through the side effects? The benefits are that actually radiotherapy together with chemotherapy allows for a very high cure rate in nasopharyngeal cancer that Dr. Chong would have told you earlier. And you can see that if you have stage 1, the chances of being alive at the end of 5 years is actually very, very high. And you're looking at 99 to 100%. And even at 10 years, this number doesn't drop very much. And it continues to be about 95%. And for stage 4, you would expect about 70% of patients to remain alive at the end of 5 years. So that is actually quite a good outcome for a cancer. And that is really because the cancer itself is very sensitive to radiation and chemotherapy. So what are the benefits of the advances in radiotherapy? And I think as the technology has advanced, we are beginning to see less and less side effects and also improved cure rates. And the improved side effects will include things like the dry mouth improving, and with the radiation beam becoming more focused, with new technology like proton therapy emerging, we would expect this trend to continue. And the other thing that we have learned is that patients benefit from having a team of healthcare workers taking care of them. And this would include our radiation therapists, the nurses, the speech therapists, the dietitian, the dentist that I spoke about earlier. And with IMRT, we have seen improvement in cure rates by about 20% over the last 2 decades. So finally, what do you expect? You know, so before we actually start the radiation treatment during the radiation treatment and after. So let's go through them one by one. So before, as I said, there is a whole list of preparation work and list of people that you would need to meet. We would do a scan, and we will also do that mask fitting. And once that is done, we'll be doing the radiation planning. And during the radiotherapy itself, you would expect to come to the radiation department on a daily basis. It generally takes about 15 to 20 minutes to complete the treatment every day. And you may also expect to get weekly chemotherapy depending on the stage of nasopharyngeal cancer. And each week, what happens for the radiation side is that we would usually review the patients to make sure that the side effects are what we expect, and also to manage the side effects to help the patients cope better with the treatment. And the dietitian usually sees our patients twice to 3 times over the entire course of radiation. And so that's a 2-weekly frequency. After the treatment, we usually do scopes, and that would help actually to assess whether the tumor is still there. We wait till about 4 months before we do a final scan to see if the tumor is still actually present. And I would say that more than 90% of the time, regardless of stage, you would actually find that the tumor is no longer present after this treatment. And you would also expect at follow-up to have a scope done every 3 months to look for recurrences, and scan every year for the first few years after the treatment. So that is what you would be able to expect with regards to the treatment for nasopharyngeal cancer using radiotherapy. So how do you might ask, how might one prepare, and I think this is where I always tell patients you need to really go back to basics. And many of us lead really, really busy lives. And when preparing, this seems almost like a no-brainer. And like I said, because this is really a very successful weight loss program. And when we actually ask you to eat, it is really to kind of make sure that you get into a routine whereby you have regular eating habits, and it would help to actually also give you a healthy start in that sense to the weight race. Rest, we usually encourage patients to actually take time off work, because this is actually a treatment that requires a fair amount of commitment and a lot of lifestyle adjustments as well, especially with regards to diet. So I think taking time off work is really important. And last of all, prepare the mind. I think if you talk to patients who've been through this treatment, they would tell you that it really isn't an easy treatment to go through. And I think a lot of it is really just having that mental strength to last the journey. And so, it's almost like doing heavy lifting. So we've come to the end of the talk. It was a very short one, a fair amount of information. So if you have any other questions, please contact me. And we're happy to also answer any questions later on. Thank you very much.
Thank you. Thank you, Dr. Ho. Thank you so much for your presentation on the radiotherapy for nasopharyngeal cancer, what to expect as a patient. We have lots and lots of questions in the Q&A, and the questions may be posed, differently or not exactly to its order because they are coming. We may have answered the bottom part of the questions and then you come to the top. So, we will ask for your understanding in that. So let's look at the questions to the Q&A. Before we start, we have a lot of questions regarding head and neck. When you sleep, is it because of the pillow? What about I have lumps and I have these lumps on my back, on my neck, and things like that? I was just wondering, could any of the doctors actually answer these questions that we have about, sleeping, the head and neck, and discomfort from resting?
Maybe I'll answer that.
Yes,
Thanks,
thank
Heidi.
you.
So I think generally neck discomfort and shoulder discomfort during sleeping is probably not a common symptom of head and neck cancer. But never say never. So if you do notice that there's any neck swelling especially, or any of those suspicious symptoms that we mentioned earlier, then do see us. I guess probably it'd be more likely that all these symptoms may arise from the muscles and the spine and the sleeping position, which usually is not related to cancer. Yeah.
Thank you. We have some questions here. Does the papillary thyroid cancer metastasis towards the thoracic spine?
I'll answer that.
Cool.
Thanks, Ivy. So the in general, yes. So the thoracic metastases or the spinal metastases for papillary thyroid cancers is something that we do see. Thankfully, it's not terribly common, but certainly it's one of the sites that we are usually on vigilance for when we have patients with known cases of papillary thyroid cancers.
And it's because this is like the next target point, which is because it's close to it.
That's not necessarily so. So when we talk about metastases to the spine, it's usually through the bloodstream, what we call hematogenous spread, and that can actually go into a multiple different areas. But what we do know, there are some specific cancer cells that target the bone, such as the thyroid and the prostate.
Thank you. And what scans can be done post thyroidectomy to scan for metastasis?
Yeah, so that's an excellent question. I think that one of the utilities of the scans would be a CT scan, and that could actually target a lot of different areas, like what you mentioned, the spine. We can also look at the lungs. We can also look at the liver. There are other scans that can also be used. In some cases, we use radioactive iodine to try to label these metastases, and that we can actually see them light up. There are other scans as well, such as PET-CT, that can also be used. So there's actually a multitude of scans that are at our disposal in this day and age. But I think for the specific site or any concerns, that should be left to the individual clinician.
What if the person is actually allergic to iodine or glucosamine or even shellfish? Should they still go to the radioactive iodine therapy?
Yeah, so that is something that has been actually discussed previously in international meetings. So one of the things that we do know is that a lot of patients are labeled as allergy to iodine. That sometimes is not actually the case. And I think there are multiple reports that have shown that patients with known what they deem to be iodine allergy from contrast mediums in the CT undergoing radioactive iodine with actually no real side effects or allergic effects whatsoever. So I think in this, it's probably best to have a personal conversation with the radiation oncologist or the nuclear medicine physician about that.
Yeah, maintaining a very close and honest relationship with your doctor, your oncologist is very important. Expressing all your concerns and discussing, what and mitigate, whatever risk and whatever concerns is important for the road of recovery. What about the papillary cancer metastasis? Does it affect the hemangiomas in the T6, T7? This is a very specific question, and T10 area. I guess this is something that the person is going through, or someone he knows or she knows is going through. So they're asking, how this is shifting. Where does it go? How is going to be affecting it? Yeah.
Yeah, it seems that this is a really specific question. I think it's difficult to comment on it without actually seeing the individual imaging. In general, I would just say that for papillary thyroid cancers to affect the hemangioma of the spine is actually fairly uncommon. But certainly, the first and most important thing is to make sure that this is indeed a hemangioma of the spine.
So quick question is about CT scan. How often do you do that? Every 6 months? So during treatment, you would have other markers to check, correct? To see if the treatment is working, etc. But thereafter, how often are you doing CT scan? Or are you rotating CT scan with other scans? Like PET scans? Anyone taking these questions, in terms of treating ENT cancers? Did I drop off? So how often do we do scans in terms of, during treatment and thereafter? Because the concern is that when so many scans are concerned, it's actually radioactive, which means it can be cancer causing.
Right, so let me answer that. So in general, when we diagnose head and neck cancer, we stage the tumor using either a CT or MRI scan. And sometimes we do something called a PET scan, which scans the whole body to look for a distant spread of the cancer. Very generally, about 3 or 4 months after treatment is complete, either surgery or radiotherapy or chemotherapy, we will repeat another scan to make sure that the tumor has completely disappeared. And then sometimes at about a year, we may then scan the whole body again. And again, this is very general. It is dependent on the particular doctor that's treating. Subsequent scans may then depend on the stage of the cancer, whether it's something aggressive. Sometimes it's a very early stage when we choose not to do frequent scans. I don't think that these scans are going to increase the risk of developing another cancer in and of themselves.
Thank you. Thank you. And the last question on this in terms of thyroid, I mean, not last for today, but do a person see an ENT oncologist post thyroidectomy?
Yeah, so in terms of ENT or, I mean, for thyroid specifically, I don't think there's there are a lot of other doctors who actually treat thyroid cancers. ENT is one of the subspecialties do it. General surgeons as well will deal with thyroid cancers. We have the radiation oncology the nuclear medicine doctors who deal with that, as well as some of the endocrine doctors have deal with it. I don't really think that it necessarily has to be an ENT, as long as someone who's trained and has a good experience in terms of dealing with thyroid cancers would be adequate in terms of the follow-up.
Thank you. The other question is this, could people who goes for normal health screening where they do cancer markers with their blood work able to find out about thyroid cancer, nasopharyngeal cancer, etc., etc.?
Maybe I'll take this question and I can probably answer both of them. So in terms of thyroid cancers, there's no real blood investigation that has been shown to have a very good predictive value. So the answer for that is no. On the other hand, when it comes to nasopharyngeal cancers, and what Dr. Lim, as well as what Dr. Chong and Dr. Ho has shared with us, is that this is related to a certain type of virus. So we can actually use certain blood investigations to identify and to basically screen the patients for any risk of developing nasopharyngeal cancers. However, I think overall, we have to be aware that this is a screening tool and it is not a definitive. So I think what we do see from time to time is a lot of patients who do the screening and they're really very worried and very frightened when the test may come back positive, but that does not actually indicate a definite nasopharyngeal cancer. It just shows the presence of the Epstein-Barr virus.
Are people with hyperthyroid and hypothyroid condition more prone to thyroid cancer?
So this is something that we have seen, and a lot of our patients ask that. So it's actually two different elements here. When we talk about hypo and hyper, we're talking about the function of the gland. When we're talking about cancers, we're actually talking about the physical change in the gland. In general, the answer would be no. Patients who have hyper and hypothyroidism are unlikely or not at a higher risk of developing differentiated or papillary cancers.
Thyroid nodes, yeah, thyroid nodes. So how do you treat them, apart from surgery? Is there any other treatment that we could do that? Do we do it immediately or we observe?
So thyroid nodules are basically a terminology, and all it is what it really means is a thyroid lump. It has to be worked up to differentiate between a benign nodule versus that of a cancer. When it is a cancer, then certainly the treatment in most settings would be surgery. In patients with benign thyroid nodules that are small, they can generally be observed. Certainly, it has to be followed up to make sure that there's no changes towards it.
So the question is that so if you're not tested, but then you have gagging, or if for no reason when you're not talking, even you choke on your own saliva and things like that, is this a thyroid issue or is this a nasopharyngeal issue?
So this is, I understand the question, and it's something that has been brought up by a lot of our patients. For a thyroid nodule to cause gagging or swallowing difficulties, these tend to be really large thyroid cancers. By and large, this should not be the only symptom that they would feel in their presentation. And if it is the only symptom that they do feel, it is quite unlikely to be secondary to a thyroid cancer.
So the small nodules appear after post-thyroidectomy, and the patient is, again, like before mentioned, allergic to iodine, what treatment besides RAI?
So in terms of, this is one of the things that we do see from time to time. I think this is quite a common issue, and just wanted to be to point out that not all lumps in the neck after thyroid thyroid removal would be indicative of a thyroid cancer. And what is well known as well is that there are a lot of times that these actually don't need to be treated at all. We can just observe them, and if there's no progression, and we've seen that for 10, 20 years, there's no change at all, they can actually just be observed. There's no real need to be invasive or treat them actively.
Okay, and if patient has already undergone surgery to remove the thyroid, both left and right, including the lymph nodes, and have already iodine therapy, but the TG level remains high, what kind of post-treatment are you suggesting? Is lungs going to be the next target, or what can be done?
Yeah, so this is once again a really specific question. I think what's important here is to identify what the levels of the TG is, and whether there's a trend, whether it's increasing or whether it's decreasing or whether it's being stable. Certainly the clinician who is addressing this this patient needs to be vigilant to look out for possible recurrences or even distal disease. I would probably, on these lines, it would be important to do serial monitoring using the ultrasound to look at the local site and looking at the distal extent using CT scans from time to time. This is obviously something that is very delicate. I mean, you can't possibly be scanning every time the patient comes back to the clinic. So that has to be actually monitored closely with the primary physician.
Thank you. Thank you very much, Dr. Yu. We now turn our focus or our spotlight to NPC. The quick question is that can NPC be actually screened?
I guess I'll take the answer.
Yes.
So as what Dr. Yu has actually mentioned, there is a possibility of checking the blood test. Doing a blood test to see the amount of EBV virus in our body. And some studies have actually showed that if you have a high and persistent EBV DNA pickup in the blood, then patients should go for nasal endoscopy as well as MRI scans to look for NPC. So that's a form of screening method. Having said that, in terms of the frequency, it's still not defined. And in terms of how high is high, what's the how persistent is persistent, all this are still not defined yet, which is the reason why at this point in time it's not incorporated into the Singapore National Cancer Screening Guidelines. So that is a possible method. The other method which some older methods or some clinics may have provided, and I think one person has actually asked about it, was doing antibodies for EBV. So that is the kind of older method. So it is also possible for screening, but I think as what Dr. Yu also highlighted, there is always a limit in terms of the accuracy of this test. So just because it's high and it's positive, it doesn't mean that you have NPC. But of course, if it's positive, it may warrant further investigation, especially if you do have symptoms and if you have risk factors such as family members with NPC.
So with high amount of Epstein-Barr virus, EBV, should they avoid sharing food or utensils with the rest of the family?
So theoretically, you're right. EBV is spread primarily by saliva, so it can spread. But having said that, the EBV was probably in the body for a long time. And when it happens, you do not know. So a lot of times we actually have it since we're young. So I don't think that avoiding of that utensil sharing for this period of time will help. In all likelihood, maybe your family members also has EBV. It's just a matter when it reactivates, when it's higher, when it's persistent. So I wouldn't go about recommending to avoid sharing utensils, but of course, I understand where this concern is coming from because theoretically, it is spread primarily by saliva. Yeah.
So, stomach cancer, they have the same thing, right? People with stomach cancer and liver cancer, stomach cancer, yes. And, it's also transmitted through saliva and things like that. So, would you say in general, we should try to avoid, what our grandparents used to do, sorry to the grandparents, they're all gone, blowing at the food or some of them even like put it in their mouth to turn it cold, then they put it in the kid's mouth, and of course, the other thing is with a lot of double income families where they actually have their helpers helping them, should that be included in the pre-screening of the helper before, they commence their full employment with the families?
So I think the answer is, I don't think it will make a lot of difference. So no, as I say, it's endemic. It's actually everywhere. And you probably got it not just from, your family members from young. It could be from your boyfriend and girlfriends when you're kissing in future and things like that. It's just everywhere. So I don't think we have to resort to that. But certainly what we can do, for instance, like for HCC, there are vaccination. For instance, for hepatitis B. So if there's, of course, a family history of that, your family members is known to have hepatitis B, then you should go for vaccination to reduce the risk of you catching the virus.
Okay. And one of the questions, the concern is that chemotherapy affects hearing and nerve, like pinning sensations in the long term. What can be done? Is there any physiotherapy whatsoever to prevent those?
So they are absolutely right. Chemotherapy can affect hearing as well as the small nerves in our fingertips as well as our soles. So patients do get some tingling sensation. Some patients complain of numbness. The good news is for the tingling sensation and numbness, it gets better as time passes. So usually it's worse maybe for the first 3 months after chemotherapy. And over time, it gets better. Usually after 1 year to 2 years post-chemotherapy, the incidence of it or the severity of it will be very mild. Some patients do find that doing exercises like stretching very helpful. Some patients also find vitamin B12 supplementation helpful. If there's also pain associated with it, doctors can also prescribe some painkillers that targets nerve pain, but rarely you have to resort to that. And what I usually advise patients is to keep themselves warm. Such numbness or tingling sensation usually get worse with exposure to cold. So it'd be helpful, for instance, when they come to cancer center, it's very cold, wear gloves if necessary, try not to take food out of the fridge. So all this would be helpful to help you get by your daily life. For the hearing wise, unfortunately, part of it can also be due to the radiotherapy, and that usually gets worse as time passes. So again, patients may try to get by it by getting a hearing aid. Sometimes the ENT doctors will take a look into the ears and see if there's any other things that we can address. For instance, sometimes there's water in the ear. They can do other things to help the hearing to get better.
And this, I'm sure it will be assessed before radiotherapy to see if it's suitable, the spot, etc. Because they would see whether radiotherapy normally have an effect thereafter, which means it's a later effect that certain other organs is being or certain being affected. Correct. So the question is this: so before someone qualifies or may I use the term earn it to actually have radiotherapy, there will be assessment to be done, correct? And this will be, of course, be explained to the patients for them to choose whether they would choose that course of treatment, although it will be highly recommended. So what are the assessments that would be done for radiotherapy versus chemotherapy?
Dr. Francis, can you address the radiotherapy factors?
I'll take that question. It will be unfair to me once you answer that. So I think certainly we will do multiple tests, prior. As I explained, I think the first is actually to see the doctor, and the doctor would basically assess. Typically, most patients will be fit for radiotherapy, with the exception of patients who have some rare conditions that make them very, very sensitive to radiotherapy, and they may get very severe side effects. So in those cases, we would actually counsel patients for alternative treatments. Secondly, I think for head and neck radiotherapy, we would be quite standard to get most of our patients to see the speech therapist, to see the dentist, and they would actually help us to do pre-treatment assessments to basically optimize patients. By far and large, these assessments do not exclude patients from treatment, but rather prepare them better for subsequent treatment. And then the last one would actually be the CT simulation that I said, where we pick a mask and we get the patient to lie down. And this is a step where some patients who have claustrophobia, for example, may have some issues coping with those. And of course, on top of all that, we usually get our nurses to counsel patients on skin care, mouth care, and those would be quite standard as well. Hope that answers the question.
Thank you. And
maybe Ivy, I will add to that also.
Yes, thank you.
So for chemotherapy assessment, of course, we will see the patients, we'll see how fit they are, whether they have any medical conditions that precludes chemotherapy, and often includes blood tests as well to assess the organ function. Maybe I'll also give some airtime to our Jerry Onco service, which Dr. Francis is also involved. I think I saw one of the questions, someone was asking, if patients are 60 years old and above, are they fit for radiotherapy?
Yeah.
So, it's often a concern from patients whether, am I too old enough for chemo or radiotherapy? So we have a multidisciplinary team consisting of doctors, which Dr. Francis is one of it, my colleague, Dr. Angela, as well as a dietitian, pharmacist, and basically they will actually assess the patient's fitness for treatment. They will actually recommend and say, actually you're not too old by assessment based on your medical condition. So that will actually help patients to decide and give them some confidence that actually they are so-called good enough for treatment.
How treatable? So we have different age. So you answer the questions about someone that's 60. And what about somebody that's very young at 23 years old, diagnosed with NPC in 2018, 6 cycles of chemo, and then 20 I think more than certain sessions of 35 sessions of radiotherapy, and now it has spread to the liver and bone. What is your prognosis?
I'm really sorry to hear that the cancer has actually came back and relapsed. And of course, the patient is pretty young. So certainly we are happy to offer more treatment, because I would assume at 23, definitely want to try our best, for the patient. There are available treatments, for instance, chemotherapy, which is standard. I've also mentioned about the promising immunotherapy. In NUH right now, we do have clinical trials where we do give immunotherapy plus minus with another medicine to see whether they can actually make the immunotherapy better. And certainly I have patients with very promising results on this study. So I think immunotherapy, whether it's investigational or, as I mentioned in my slides, it's something that has also been proven in other countries, in China especially. These are things that we can consider. So we are happy to see the patient but I guess now maybe limited by the COVID, but certainly we can offer some consult. Yeah.
Yes. And immunotherapy, would that be a natural cause versus chemo and radiotherapy, or this comes as something because it's either or because something can't be happened?
Yeah,
so
that's a good question. So right now, we're not too sure. That's the answer. Immunotherapy has been around for many years, largely started in like melanoma, lung cancer, kidney cancer, and now coming to head and neck as well as NPC. So it is something new when we're talking about NPC. So right now, I would say that it's still not quite standard of care, although as I mentioned in my slides, they're very promising based on some other studies that have been done overseas, mainly in China, because that's where it's endemic as well. And we also have clinical trials in-house that give immunotherapy. So we have some very promising results. But right now, it's still in the so-called investigational or experimental phase. I also saw somebody has also asked a question about giving how else we can improve the cure rates besides chemo and radiotherapy. So again, we have also an in-house trial now whereby we are giving immunotherapy with chemo and radiotherapy in patients with locally advanced NPC. But whether that will give you a higher cure rate, I'm not too sure, because that's why we're doing an experiment, we're doing an investigation on that. But that is something very promising as well. So right now, immunotherapy we have given either on its own or in the late stage, or right now we have a clinical study with a chemo and RT in the locally advanced stage. And I think we'll only know after all the studies to see whether immunotherapy should be given on its own or in combination, or how we should give it best. Yeah.
So quick question is this, after surgery, should the lump be residing, or is only after chemotherapy, or it is, during radiotherapy? So there's a question here that asks, do they still feel the lump? Do they still feel the hump, before, after, etc.? So how does it work?
Maybe I'll just take that question quickly, since for radiotherapy, it does take some time to work. So commonly patients do feel lump during the treatment, even immediately after the treatment. But usually if the lump still persists more than 3 months' time after the end of the chemo radiotherapy, then we do need to do further investigations. And we may have to do investigations earlier if the lump is growing. I think that would be more concerning.
Is there a concern between soft lump, hard lump? And is it possible to still get culture from a hard lump?
So cultures, usually we do like a biopsy to see whether there's cancer cells. I think that's what we're most worried about. If there's infection, we go by clinical examination, the symptoms and signs. So you can get biopsy from soft lump or hard lumps if they are really lumps. I don't think there's a difference between soft and hard, but certainly we are always more worried if there are associated symptoms, painful, if it's especially growing, then that's when we are more concerned.
Okay. Next question is this. Is hyperthyroidism more prone to neck cancer or hypothyroidism more prone to neck cancer? Or thyroid cancer per se? I don't think it's neck cancer, but thyroid cancer.
Yeah, I'll answer this. So I saw that in the questions as well. It goes back to relate to what I think what I mentioned is that these are actually elements of the function of the gland and not so much the structure of the gland. And these are usually not associated with the papillary thyroid cancers that we've been talking about. There are certain concerns, obviously, that in some small subset of these patients who they may develop cancers, but I think it's prudent to understand that thyroid cancers the risk of it is already relatively high. Whether or not you have hypo or hyper doesn't actually increase or decrease your risk in terms of getting thyroid cancers.
How do you take care of your thyroid?
So I think this is something that's really difficult I would assume what this question's references would be, how do you minimize the risk of developing thyroid cancers? Yeah. But as what I shared, I think in the talk would be, there's really nothing that we can change in our environment. There's no food related or any habit related behaviors that we can actually change to increase or decrease the risk of thyroid cancers. I generally give the advice of a balanced diet. I think we had this talk as well about multiple imaging and things like that. And so we do know that if someone who goes for a lot of, there are some people who do, health screenings, scans, and things like that. These are radiation doses, and if not necessary, probably would be best advised against doing these imaging.
Why women have higher chance of contracting thyroid cancer?
And that is a really good question, and that's actually something that we are still not exactly sure. I don't think there's any good clinical evidence as to why this is the case. We do seem to think that they are diagnosed earlier because women in general are more aware and tend to seek medical consults earlier than men. And that's the reason I think we're having that disproportion in terms of the age presentation. But as to why females more than males, I don't think there's anything right now that has a strong evidence to back that up.
I mean, sometimes, when for no reason the women is putting on weight, they see their doctor, they get a blood test. Of course, that's being detected. But childbirth, I understand that childbirth can also tilt the thyroid functions. Are those also some factors that would lead to further chances of getting thyroid cancer?
No, I don't think so. I mean, I don't think that childbirth has a direct correlation in terms of developing a thyroid cancer. Certainly when there is, during childbirth or during pregnancy, there is some interplay and some increased demands on the thyroid gland and the hormone levels. But that in itself, I don't think has a strong association with developing thyroid cancers.
Thank you. So thank you very much, Dr. Yu. Next question is dentures. How does the ill-fitting dentures, affect or cause the cancer?
Yeah, that's a good question. So the theory is that it's probably because the denture doesn't fit well in the lining of the mouth. So it causes recurrent trauma, abrasions, and the skin breaks down and it regrows. And with many cycles of that, it can actually lead to the cells transforming into cancerous cells. There's been studies to show that ill-fitting dentures can actually increase the risk of developing cancer of the mouth by almost 3 to 4 times.
So do you suggest that, or would the part of the therapy is that if the person needed denture, sorry, let me rephrase this. Would this treatment actually cause them lose teeth if they have oral cancer?
So the answer is yes. Sometimes as part of the oral cancer surgery, we may need to remove the teeth. Sometimes patients have unhealthy teeth to begin with because they may be chronic smokers or drinkers. So there are many patients who do require dentures post-treatment, and we do get our dentists to see them to make sure that their dentures are well fitted.
I mean, I've seen the photographs, you know, and all these years, and whenever we see the photographs, I mean, they do look like the person is actually a smoker. So you would say that right now, all the cases, majority of them are actually smoker?
I would say yes, the majority of them are, but there are definitely a significant number of patients who actually do not smoke and do not drink and still can develop cancer of the mouth.
Yeah, because you have the NPV possibilities too that has caused that too.
Yes, so HPV may cause cancer at the back of the throat. So
yes,
that's the area of the tonsil and the palate. Yeah.
HPV. Okay, thank you. The other question we have this is that there's quite a few questions that has just come in that's very, very case specific, which means is very personal, you know. So let me take a look at this. Let's talk about immunology therapy versus conventional therapy. There is this question here. Sorry, just give me a second to screen through them. We still have about 32 questions in the row. And okay, let's look at this. Would there be any potential or increase or decrease effect on other organ functions when immunotherapy is being practiced?
Yep, I'll answer that question. So immunotherapy, there is still a chance that we can affect other organ function. This is actually a very rare side effects where we call it immune-related adverse event, meaning when we give immunotherapy, as I did mention also, what it does is to awaken your immune system. And sometimes the immune system may then end up attacking the rest of the body, and this can include even the liver as well as kidney function. So have I seen it happening in other patients? Yes, I did. And I do see sometimes it can be really quite bad. But generally, this risk of happening is actually low at 10 to 15%. Of course, we still quote a small risk of death from this very bad side effect. Yeah.
Thank you. Thank you. I just seen this questions back again. Thank you, Dr. Chong. Thank you. A dental appointment, you know, there's a gum infection and been using antiseptic gargle to treat, but the symptoms does not go away and been having headaches from time to time. And so they've consulted a neurologist and MRI scheduled for October. Are these symptoms of ENT cancer?
I would say that these symptoms are rather non-specific. It's not usual to get cancer causing recurring gum infections. But headaches, yes, actually it can be a possible symptom. Even NPC can present first with headaches. So I would say that if the person who asked the question is very concerned and hasn't been seen by an ENT doctor or someone familiar with head and neck cancers, then please do come to see us. We'll definitely be happy to see you.
So one other thing is this, sensitivity over the past years, together with persistent ulcers at two corners of the upper gums, anytime that is contacted with toothpaste or spice, you know, like chili, curry, etc., it will pain all over the mouth. And no cancer diagnosis. I don't know how that was being determined, but the dentist has advised KIV. The person actually has a history of iron deficiency. Is this a cause for concern?
So again, it's a bit difficult to say without having seen the patient himself, but what has been described sounds like something that we call burning mouth syndrome, which has actually many possible causes. Iron deficiency is one of them. It could also be low levels of certain elements in the body, such as zinc or even low blood counts. Again, I would say that, you know, if the person has not been checked out properly, then please come to see us and we can just make sure that there's nothing suspicious in the mouth or the rest of the head and neck.
Vertigo with episodes of vertigo and you know, where symptoms like vertigo, probably not vertigo as vertigo, because when you check the ears, the stone is not moving, but symptoms like vertigo, and the person actually has occasional ear blocked. Is this a cause that they should see an ENT specialist?
Well, I think that they should see an ENT specialist, probably less because it's due to cancer, but because we do see patients who have ear problems that lead to vertigo. And I think that vertigo is a very troublesome symptom that we can definitely help them with.
Thank you. So I saw that in the answered questions about the muscle knots and lumps at the side of the neck and the shoulder, yes. And I was just wondering, is there cause for, you know, with the knots? other than, exercise, seeing a musculoskeletal specialist, what else can be done? Would this be correlated to anything else? Any doctors taking on the questions about, the head and neck in terms of sleeping postures, pillows, and muscles?
So I
Just
think I've
coming up.
answered this question on the chat as well as earlier on.
Okay, so for the
This neck
audience,
stiffness is usually probably not a medial muscle or spine issue. But again, if you have any neck swelling, any neck lump, any suspicious symptom in the nose, throat, head and neck, please get it checked out. But of course, it's probably less likely when it's due to the cancer.
okay. The removal of the thyroid gland, partially or full removal, would it cause, weight gain more easily? And any chance or any ways to maintain the weight gain? Thank you, Dr. Lim. You need to unmute yourself, Dr. Yu.
Yeah, so sorry. Yeah, so in terms of weight gain, that could be an element of not enough thyroxine hormone. So I think one of the issues with that would be to monitor the thyroxine levels and to make sure that your thyroxine levels are adequate. So hypothyroidism or low thyroxine levels have been associated with clinical weight gain. So it is important to go back to the physician to take a look at that and then to do a blood test just to make sure that the appropriate amount of thyroxine is given to the patient.
Thank you. Dr. Ho, I think there's some questions that's correlated to your area of expertise. Would you answer those questions for us, please?
Yeah, so I think there is some interest. I think there's also been some publicity about proton therapy, which is a new type of radiotherapy that's going to be available in Singapore. I think, unfortunately, COVID has derailed those plans. I think it was supposed to be available as early as earlier part of this year. But I don't think we'll be seeing prototherapy being available this year. They are, the various sites are both at the National Cancer Center at Parkway and Biopolis, the 3 sites altogether. They're all kind of delayed currently. And I think the earliest we'll see any proton facilities being ready would be sometime from next year onwards. In terms of the benefit, I think you wouldn't see superior survival with proton therapy treatment, but what you do expect to see in that selected cases, you would expect less side effects. So that is the predominant benefit of proton therapy. So hope that answers the questions with regards to that.
Yes, I remember that proton machine. It was like a huge spaceship kind of looking thing, right? I think it was like 2 or 3 years ago when we were doing it live sessions. I've seen the slides before. So, I think there are people who are looking forward to see how that developed in Singapore. So thank you, Dr. Ho. Next, I'd like to invite Prof. Loh back and to the stage or to the screen to give us his remarks for today's session. Prof. Loh.
Hello, hi.
Hi. You want to turn on your camera? Thank you.
Hi. So first I just wanted to say before the meeting ends, my appreciation to the staff of NCIS who organized this, to Eunice, Janet, and of course to yourself, Ivy, for helping organize this forum for the public. The second thing that I wanted to make is we are in this time of COVID, and I think that there are many questions, especially with regards to patients who are undergoing treatment or have completed the treatment, whether they are suitable for vaccination. And the answer is yes. In general, you are suitable, and in general, it is safe for patients to have vaccination. In fact, all our patients, and if your relatives who have cancer, should seriously consider getting the vaccination, because it has clearly been shown that it will protect the patients if, just in case they do get COVID, that their symptoms will be certainly a lot milder, and they run a much lower risk of getting into trouble, for example, into ICU and so on. So these are all very important points, and I know that many patients come to us being very concerned about whether they can take the vaccine. It is largely safe. If you are a patient in NUH, and if you are concerned, go to your doctor. Your doctor will confirm with you whether you are okay to have the vaccination. And in fact, we do have a vaccination center within the hospital that can provide the vaccination for you. So I would encourage every one of you to do that, whether it's yourself as a patient or whether it's your relative who have patients, especially the elderly. Thank you.
Thank you, Dr. Loh. Just hold on a moment, Prof. Loh. So this is a question that comes from someone that has recently been through the thyroidectomy and lymph nodes removal recently. We don't know how recent it was, and is the person actually able to get the mRNA anti-COVID vaccine, or should they wait for the Novavax type of vaccine, or the Sinovac? I guess what she's saying is that the Sinovac type of vaccine.
It is safe to get the mRNA vaccine. And in Singapore right now, the vaccines are available are largely the mRNA vaccines. The Sinovac is available, and if you wanted to use or to have the Sinovac, it is really just purely out of choice. It is certainly not going to be because we think that there is a safety level because you've had thyroid cancer and the surgery that you had, as well as the radioiodine that you had. Therefore, you have to take Sinovac. That's incorrect. You can take the mRNA vaccines.
So the quick question is this, and for this year, this question comes up a lot, especially with cancer patients, etc. And all the oncologists and the doctor would say, yes, please go ahead. But the vaccine center would actually stop. So give you a live example. My father has just finished his radiotherapy for his prostate cancer, and he went for his vaccine. He got his first shot. When he was scheduled for his second shot, they asked him questions, and they said, you cannot have the second shot. So there were also other situations like that when they go because, the government, everyone has says, please go, and then go, then they realize they can't do it. So what is the waiting period and what should they do during this waiting period? Because they do go to the hospitals, they do have to travel for their treatment, etc. What would be what would be good for them to know how? Because they're obviously weaker after, or during treatment.
So my advice would be that, again, by default or in general, all patients, especially if you have been treated and you are in remission, you are well, there's really no reason why you cannot take the vaccine, unless, of course, there are other reasons. For example, you have very severe allergies, right? At the vaccination centers out in the public, you have to realize that they deal with a large throughput of patients. And clearly safety is something very important. They don't want to just liberally give the vaccination to anyone. So obviously they have a much lower threshold in terms of safety levels, and therefore in your situation, your father may have a situation where he may have reported something, or they may have, through the questions, they may have decided that for safety purpose, that it would be best that they do not get the vaccination. Now, if that arises, in general, the vaccination center where he went to would have then advised him to seek to have a consult with someone, and that someone is in one of the hospitals, right? And so when they then go to the hospitals to have that consult, our consultants will determine whether it is safe or not safe to have the vaccination. And if it requires a vaccination, whether it can be done within the hospital or back to the vaccination center, for which we will obviously convey a memo.
Okay, thank you very much. Thank you. I meantime, is there a waiting period after they have finished their last session of chemo and or radiotherapy? Then they would get the vaccine, or they can do it even when they are during chemo and radiotherapy?
So clearly, I'll leave Wan Ching to answer this, Wan Ching and Francis to answer this. But again, just as a general guide, there is nothing really to say that for sure you cannot have the vaccine if you have just completed treatment. Yes, there may be circumstances where we may not want to vaccinate during treatment. But even then, it can be safe. But Wan Ching and Francis, thank you.
Thank you, Prof. Loh. And again, it's always been a pleasure. Thank you, and have a great afternoon.
I'll let Wan Ching and Francis answer that. Yeah.
Yes. Over to Dr. Chong and Dr. Ho.
So the recommendation is to wait 3 months from the end of the chemotherapy and radiotherapy. But as what Prof. Rightfully mentioned, there's actually it's not a contraindication. It's just that if you get it soon after your chemo and RT, when your body immune system still hasn't recovered from the treatment, then the efficacy of the vaccine may be lower. But some protection may still be better than nothing. So for some patients, for instance, with advanced NPC, they are ongoing chemotherapy for a long time. I don't see myself breaking the treatment just to go for vaccine. Then I'll encourage them to go even while on chemotherapy. For some patients, though, if their chemo and RT is going to end soon, then I say maybe you wait a while. When your immune system has recovered, then you go for your vaccine. I wonder what Dr. Ho thinks.
Yeah, Dr. Ho.
And so I totally agree with that. I think by far and large, we try not to have them happening together if we can. And that's really not because of a safety issue, but more of worrying about the efficacy of the vaccine. But I think when in doubt, right, I think speak to your oncologist. I think nowadays, there is really no one-size-fits-all formulas these days. It is really a matter of balancing the risks, the pros and cons. Yeah.
Thank you. And any parting words for everyone, in your respective area of specialty? Can we start with Dr. Lim?
So what I just want to say is thanks everyone for attending, and our ENT clinic as well as our cancer clinics are open anytime. So if you have any concern or suspicious symptom, please do feel free to consult us. We'll be happy to see you.
Thank you, Dr. Lim. Dr. Yu?
Hi, thanks. I just want to reiterate the things that we talked about in terms of the thyroid cancers. Certainly, we want to thank everyone for joining us today. And certainly, if there's any concerns in regards to thyroid or any head and neck cancers, we're more than open to be able to see you at the National Cancer Institute. Thank you.
Thank you. Dr. Chong? You're on mute.
Sorry. I know chemotherapy always sounds scary, but your medical oncologists are here to walk the journey with you. Most side effects are manageable, and definitely we have promising therapies coming up. So let's stay hopeful.
Thank you. Dr. Ho?
Yeah, I think similarly, radiotherapy has also been a kind of fearful journey for many. But I think the people who have been through it will say that it's actually doable. So if you have a need for treatment, please come ahead, rather to have it treated early rather than late.
Thank you. And any parting words for us, Prof. Loh?
No, thank you very much, everyone. I just want to say that at NCIS and at NUH, we are here, and this public forum is a demonstration of the fact that we are here. At the end of the day, we just want to be able to provide information, and we want our patients to be well. And in whatever way that we can, we'll do our best for everyone.
Thank you, Prof. Loh. Thank you everyone for joining. Please do not leave the room. And we are actually putting up the feedback form survey, for this webinar. And you will see it immediately right after this. And for those who are watching in NCIS or 365 Cancer Prevention Society Facebook live stream, please scan the QR code or visit the URL in the pinned the comments, and give us your feedback. Your feedback is very important to us. I would like to take this opportunity to thank NCIS for the opportunity for me to volunteer again. Thank you, Dr. Lim. Thank you, Dr. Yu. Thank you, Dr. Chong. Thank you, Dr. Ho. Thank you, Prof. Loh, for having me. Thank you very much. And of course, the angels behind this event, Eunice and Janet and crew. This is extremely, heartwarming to know that, you don't stop looking after your people, even during this period of time. And at the end of the session, we, as I mentioned earlier, during the start of the event, we are going to be sharing some upcoming events, and you will be seeing the slides that's coming up. So I think, Eunice, you can now put up the slides, and thank you all the doctors. Have a great weekend. And for all the participants, please stay on, please stay on. So you will see that we have a few events that's coming up, an online concert, tapestry by NCIS and Hwa Chong Medical Society in August. Winning Against Cancer webinar in August also, Protecting Your Skin, Preventing Skin Cancer webinar in September. These details will be shown, use the QR code, scan for it. If you have any questions, go to the NCIS website at www.ncis.com.sg. We have come to the end of the session. We thank you very, very much. And again, thanking our speakers, Dr. Lim, Dr. Yu, Dr. Ho, Dr. Chong, and Prof. Loh. And at the same time, our sponsors from Electra and MSD Pharma, who helped to make this event possible. And of course, 365 Cancer Prevention Society. You can still watch today's live stream from the Facebook, from NCIS Facebook and 365 Cancer Prevention Society Facebook page. And do please fill up the feedback form. Your feedback is very important to us. We aim to, bring you events, information, knowledge, and awareness of different cancers, different treatments, and to ensure that you are healthy, happy. Wash your hands, do sanitize, and wear your mask properly. And stay safe, everyone. Have a great weekend. Don't go yet. Please do scan the codes, the QR codes, and do the feedback form. There you are. The feedback form is up here now. Thank you very much. Thank you all. There's 300 and over 400 of you actually today in the sessions. So thank you very much. So take your time, scan all the QR code, do it at your own pace, but let us know what you think. Come to the event, and I wish you all happy, healthy, and stay safe. Thank you, everyone. Thank you. Thank you, all the doctors. Thank you very much. Thank you.
Thanks, Ivy.
Thank you.